I'm Roberta Horton, Director of the Department of Social Work Programs. I think I'm fortunate enough to know most of you here. Every year, the National Association of Social Workers honors social workers across the country with the observance of March as National Professional Social Work Month. This is an opportunity for the profession to consider its history, celebrate its contributions, and look toward its future. To acknowledge Social Work Month at Special Surgery, members of our Social Work Staff Development Committee coordinate weekly tablings throughout the hospital to share information about social work-related services and programs, as well as this morning's presentation sponsored by the Department of Social Work Programs. There's lots of programs in this, because we do lots of great programmatic work. I would like to express heartfelt appreciation to the members of our Social Work Staff Development Committee. Mavis Seahouse, our committee chair, who's staffing the doorway. Juliet Kleinman and Mylan Tran, Social Work Month Planning co-chairs. Jillian Rose and Meredith Woolrich, Speaker Coordination co-chairs. Adina Batterman and Maris Pasquale, Journal Club co-chairs, and Susie Kim, with whom I share the role of secretary, as well as the ongoing support of Susan Flicks and Marion Hare. We also want to acknowledge our colleagues throughout HSS, with whom we share a passion to provide outstanding service to the patients and communities we all serve. It is in this spirit that we introduce Nicholas Lessa to my right, who will be addressing the topic of identifying and intervening with patients with substance abuse disorders. Hospital patients may often have substance abuse issues that are crucial yet challenging to address for a number of reasons. The learning objectives for this presentation are to help participants to identify hospital patients with substance use disorders during a brief intervention, to assess their readiness for change, and to effectively guide them toward treatment. Nicholas Lessa is the Chief Executive Officer and partner of Intercare Limited, an outpatient substance abuse treatment agency in Midtown Manhattan. He is a licensed clinical social worker, a master's level psychologist, and a credentialed alcohol and substance abuse counselor. He provides numerous lectures around New York City on topics pertaining to the treatment of substance use disorders. Mr. Lessa is an associate adjunct professor at the Silver School of Social Work at New York University and is also in private practice. He is the lead author of 2 books entitled Concise Guides to Mental Health, Substance Use Disorders, and his recent release, Living with Alcoholism and Drug Addiction. Mr. Lessa's talk will be followed by an opportunity to address your questions directly, which you may submit on the index cards we distributed. Those will be collected at the end of Mr. Lessa's talk, or directly to Mr. Lessa. Please take a few minutes at the end of our presentation to complete an evaluation which will help us for future planning. Please join us with a round of applause in welcoming Nick Lessa.
Good morning, ladies and gentlemen. Thank you for having me. I have a big topic to discuss in a very short period of time, and I hope that this will give you some inspiration to feel a little more confident in working with anyone who may potentially have substance use disorders. I'd like to begin by saying that it's currently estimated that 1 out of every 4 hospital admissions is related to either substance use, alcohol, or tobacco use related problems. 1 out of every 4. 25% of all the patients coming into the hospital or admitted to a hospital. So it's quite a large number. Actually, JCAHO right now has put in a proposal to require all hospitals to screen for substance use disorders at the time of admission, and that's in the proposal stage right now. But it's believed that by doing that screening on every single patient, that they will be able to reduce the healthcare costs in the United States. This is a large issue, and it is often gone neglected by many of us in the medical field. So I hope that today's topic will be helpful. I am going to be referring to SUDs throughout this, meaning substance use disorders, and I will define that in a moment. So, let's begin by talking about the use of substances. I mean, there are different levels of use of substances. The lowest level, obviously, is recreational use or social use. And when somebody is socially using, it's normally done in a social setting, usually with other people, not alone, but no one's to say that if you have a beer watching a ball game, it's a problem either. But most of the time, it's done in a social way. There's no clear negative consequences to the use of the substance, and a great deal of choice and control over one's use. You can decide, I don't feel like having a drink right now, or I'll only have one today, thank you, because I'm driving home. So there's a lot of choice and control over the use, and very few negative consequences when we consider it social use. The problem is that everyone wants to believe that they're social users. And that's when we get into a little bit of a problem area. The next higher level beyond social use is something we call purposeful use. The use itself is not just social, but is serving some other useful purpose. For instance, in order to socialize, I need to have a drink, or I need to smoke some marijuana to feel more confident, or if I want to make a presentation, I need a couple of hits of cocaine to feel more confident in my ability to make that presentation. That is becoming more purposeful in one's life. Use is becoming more isolated, maybe even hiding it, and the consequences may or may not be evident yet. But it's clearly the person may be moving towards the potential for consequences. So this is sort of a gray area, this purposeful use area between recreational and problematic use. The next two areas are actually what we define in the Diagnostic and Statistical Manual as a substance use disorder. The less severe disorder is called substance abuse. And the easiest way to define substance abuse is to say that the person loses control of the use of the substance irregularly. Okay, it doesn't happen all the time. This is the person who may go out for a few drinks every Friday night with friends, and most of the time the person has a few drinks, goes home, there are no problems. But periodically, the person will overdo it. And when they overdo it, they may black out, get into a car and try to drive under the influence, get into some kind of fights at the place that they're drinking, go home and have some arguments. The point is that periodically, this person will lose control over the use of it, and there are usually consequences, sometimes severe consequences, related to it. Okay? The problem for that individual to accept that they have a disorder is that it doesn't happen all the time. So it's much more difficult to admit that I do have a problem because it's Russian roulette. You just never know when it's going to occur when you lose control. The most severe disorder related to substance use is substance dependence. And this person regularly loses control. Pretty much the substance controls them as opposed to the person controlling the substance. So pretty much anytime somebody begins drinking, they continue drinking way beyond what would be considered safe drinking or any other drug of choice. The person is usually using alone. They may be physically addicted to the substance as well. There are often regular consequences to use. Now, we find that it's easier to treat somebody who's substance dependent than substance abuse because the person who's dependent clearly can't hide that from themselves. They know that pretty much every time they use, although there's still a compulsion to use, that there are problems related to the use. So in some ways, it's easier to treat when somebody's dependent than somebody who's an abuser. And we may all know abusers in this room. We may know the people who are substance dependent as well, but it's the abusers who keep going on and on trying to deny the problem. So our job right now as medical workers is to try to identify this in a very short period of time in a hospital setting. And what I want to present to you today is how do we identify it in a short period of time, and how do we do a brief intervention in a very short period of time? I'm talking about a 5 or 10 minute intervention. What can we do to make a difference? So, I mean, you don't have time to do therapy sessions. You have a few minutes to speak to someone. So let's talk about that today and give you some ideas of what we seem to know helps and what doesn't help. First of all, when we're assessing for a substance use disorder, as I write here, it's often not clinical work as much as detective work. Okay? Because many people want to minimize the problem. Now, they may come in and admit to a lot of medical problems to you and be very honest about it, but when it comes to the use of substances, that's when everything is fine, even if it's not. So sometimes we will not get direct information from a patient about a disorder related to substance use. And that's the dilemma we have in the field. So we often have to indirectly find out if somebody may have a problem. Now, there are some screening tools that I use at my clinic for people who are sort of coerced into coming to see me, where it's been very helpful for me to determine if they have a substance use disorder, even in people not wanting to admit to it. And this is beyond the realm of today's conversation, but there are some forms that help us identify it with some very high accuracy rates. But in terms of your work, some signs of it, and these are just a few, this is certainly not the full extent of them. Any information that you're receiving from family members, any collateral others indicating a sudden change in functioning, a loss of pleasure in previous activities, appearing preoccupied with something, appearing sneaky or dishonest, looking ill, excessive work absenteeism, especially around paydays or Mondays, could be signs of it as well. And these are just a few of the possible indirect signs. In terms of medical signs, and again, this is just a few of them, skin abscesses could indicate, the use of IV injections, difficulty undergoing anesthesia. Many people have high tolerance levels for anesthetics, and you need a very high amount in order to get them into a state of being anesthetized. Elevated liver enzymes could indicate heavy alcohol use. And again, collateral reports, just hearing it from family members, any significant others who may be involved in that person's life could be very helpful for giving some of that information. But again, it's very hard to identify it, and that's why JCAHO right now is considering using some kind of screening forms that may be able to identify these disorders right from the beginning. Before we could help anyone, someone basically, if you're going to do some kind of intervention in 5 or 10 minutes, the first place to begin is to assess how ready one is to make a change in their life. If someone is clearly not ready to make any change at all, it may not be the best use of your time to be trying to persuade people directly to receive help in terms of their substance use disorder. But just by questioning people, especially a medical professional questioning someone about their use, could begin to help move the person in the direction of reducing use. Just a simple intervention with a few questions, as we're going to go into. But let's look at some of the stages of readiness for change. And this relates to all behavioral change, and you can relate it to yourself and in any other behaviors that you've thought about changing but maybe haven't yet. The first stage is called pre-contemplation, which essentially means this is before me even thinking about changing. So this is the person who may be drinking heavily or smoking tobacco heavily and has no desire or intent to stop that behavior at this particular juncture. That person, technically we call them in the stage of pre-contemplation. They're not ready to make a change. The second stage is what we call contemplation. And contemplation means, I probably should cut down or probably should stop this behavior completely, but I'm not sure I'm ready to. There's always a but connected to that, what I should do, but. Okay? I may be doing this too much, but what will I do without it? But my life will be boring, but I won't have any more friends. So it's a stage of ambivalence, feeling two ways about the behavior. Part of me thinks intellectually I should probably make a change, but emotionally I'm not ready to let go of that behavior. And this can last a lifetime. For some of us who've struggled with weight loss and dieting, and it goes back and forth, that struggle of wanting to lose weight, then going back to putting on weight, and that could be a lifetime struggle. This is a very difficult stage to get through. The third stage is action, where the person is actually taking steps to make a change. And this person has made some commitment to themselves of wanting to make a change in their life and taking steps to make that happen. So for a cigarette smoker, it might be putting a nicotine patch on their arm. Or somebody trying to stop drinking may begin experimenting with going to AA meetings to try to stop drinking. There's some action taking. Now, what do we do depending on what stage they're at is basically to just try to move them to the next stage. And I'm not suggesting that in 5 or 10 minute interventions you'll be able to make that much of a change, but believe it or not, you can have a significant impact on moving people in these stages from one to the next by a very simple intervention, as we will speak about shortly. The job, when somebody's in pre-contemplation, meaning I don't even have any desire or intentions to change, is just to raise a little doubt about their use. So you think it's safe the way you've been using. So these elevated liver enzymes are not a real concern to you. Just raising issues as simple as that in an indirect way will get people to raise their doubt about their behavior, to raise some question in their own minds about, wow, the doctor told me, started asking me some very heavy questions about my drinking. Maybe I should look at this. Maybe I need to cut back. Just that intervention alone can significantly reduce the use of substances in follow-up studies for up to 6 months later. So you may not think that you're making much of an impact by just raising some concern, but it can actually make a significant change on behavior. So if they come in and have no desire to change, your job is just to raise a little doubt. Not directly to persuade them to change, but just to raise a little doubt. If they come in the contemplation stage of ambivalence, maybe your job is just to move them a little closer to taking some action. And if you could do that in a very brief period of time, you have done a significant benefit for that individual. And if they come into you and you meet with them and they're already taking action steps, your job is to encourage them to continue that. So 3 major strategies, or 3 essential strategies right now based upon these stages is either to raise doubt, to help move them towards action, or to encourage people to continue action. 3 questions that can be very, very helpful to just ask in a very brief intervention of 5 minutes to 10 minutes. These 3 questions predict who will make a change and who will not. And they're basically associated with willing, ready, and able. We've all heard that term before, but maybe we've never really put a lot of thought to them. But first of all, for somebody to change a behavior, they have to understand that there's importance to changing that behavior. So the first question would be, Mr. Smith, how important is it for you to maybe reduce your drinking on a scale of 0 to 10, 0 being not important at all, and 10 being very important? Just to get a sense of where they're at in terms of readiness to make some change. If they say, oh, I give it about an 8, I think it's pretty important, I stopped smoking cigarettes. Okay. Next question is, how ready are you, Mr. Smith, to stop smoking now from 0 to 10? Okay? A lot of people, you say to them, how important is it for you to stop drinking from 0 to 10? Oh, I give it a 10. How ready are you to stop drinking now from 0 to 10? Oh, not now. I mean, my birthday's coming up. The holidays are here, not now. So willingness and readiness have to be hand in hand. And the third question, which we often neglect, is how confident are you that you can actually do this? If you consider this important to change and you're ready to change it, how confident are you that you can do this from 0 to 10? Now, the confidence area is more of what the social worker would work on with the individual to increase what we call their self-efficacy, their belief that they can actually accomplish this task. That's beyond, I think, a medical staffing issue. But as a medical professional, to ask the first two questions of willingness and readiness can help even make the person themselves more aware of where they're at and more aware of raising doubt and increasing contemplation about making a change. So I encourage you to use those first two questions. Any questions so far before I move on? Anything pressing that somebody needs to ask? Okay. I take that as me being clear or no one really being motivated to care. So I'm not sure which one it is. Okay, what we know from doing work about behavioral change is direct persuasion doesn't work. Direct persuasion does not work. And I know as physicians and as medical professionals, you're often taught that your job is to prescribe, which is basically giving advice. This is what you need to take, this is what you need to do. And I am involved in a physician's residence program of training physicians to think a little differently from the behavioral change standpoint of rather than directly persuading, we have found that it's much more helpful to get the patient themselves to voice a concern or a desire to make a change. So it's a much better, rather than saying, Mr. Smith, you need to stop drinking. It's much better to say something like, Mr. Smith, what are your thoughts about not drinking any longer? What are your concerns about your drinking? What are you ready to do about your drinking? Those questions to get Mr. Smith to actually voice it is much more beneficial than telling Mr. Smith what he needs to do. You see, when somebody's ambivalent, when they're feeling two ways about it, if you bring up one side of the ambivalence by saying this is what you need to do, they will counteract and defend the other side of the ambivalence by telling you, but. And what we know from our research is something from the self-perception theory is what I believe what I hear myself say. So if you get the person to defend the status quo, to defend, no, well, I can't stop drinking, I won't have any friends. I can't stop drinking, what will I do with my time? The more they hear themselves say that, the less likely change will occur. It would be better for you to say, Mr. Smith, maybe you should just continue drinking. It would be better to do that than to try to tell them to stop. Because then maybe they'll say, well, I can't just continue like it is. Oh, really? Why is that? Well, I'm going to die if I keep this up. Oh, thank you very much. That is much more helpful. So the key seems to be getting the patient to voice the concern and voice what they are planning or willing to do. Much more beneficial. And I know, I often hear people say, I don't have the time to do this. Well, believe me, it's what will work is just a few questions, and we're going to go into some of these questions as well, so some more questions that can be helpful to get the person to voice concern or voice a desire to make some change. And we use the mnemonic device of Dawn C questions. Dawn stands for desire, ability, reasons, and need, and C is for commitment. And we want you to raise the questions according to these different areas. Desire. Mr. Smith, why might it be desirable for you to cut down on your drinking? Why do you think it might be desirable for you to cut down on your smoking? To ask those questions rather than to say, Mr. Smith, you need to cut down on your smoking. You know, what a patient will do is nod and just move on. Again, it's much better for them to voice concern. Second question for A in the Dawn C is ability. And this is not as important, again, I think, for the work you're doing right now, but what gives you the belief that you are able to cut down or stop your use of blank? What gives you the belief that you might be able to do that? If they voice some desire to make a change, that might be a good follow-up question. Well, you know, I've done it before, or you know, I could stop drinking. I stopped smoking. Oh, excellent! That's wonderful. Just for people to voice that is very, very helpful. The R stands for voicing reasons for change. Mr. Smith, can you think of any reasons why it might be helpful for you to reduce your drinking, to reduce your smoking, to quit altogether? Any reasons? Or some people put it in, can you list 3 reasons why it might be helpful to reduce your use of blank? Anyway, any questions related to reasons why it might be helpful to make a change? N stands for need. Why might you need to reduce or stop your use of blank? And before you end any intervention with them, the question, it's the closing question. It's like closing a sale of any situation is, Mr. Smith, what do you think you'll be doing about your smoking? Mr. Smith, what do you think you'll be doing about your drinking? Get some commitment. Get some action step from the individual themselves. Rather than saying, okay, so I'm going to write down you're going to cut your cigarettes out, cut down by 10 cigarettes a day. When you're prescribing it, it doesn't mean there's any commitment behind any of that. But you got a very good chance of a commitment and people actually doing something if you get them to voice it themselves. And you're giving them the respect to make the decision for themselves. What do you think you'll do? If they tell you they're going to take some steps, praise it, affirm it, smile. Make them know you feel good about what they're agreeing to do. And that could be simply it. That could be the end of that intervention. Give them a little stroke at the end of that commitment. It's also very helpful, by the way, if there's any significant others who may walk in on that or later on and say, you know, your husband today, he made a commitment to stop smoking. Do you believe that? Now that strengthens the commitment by letting other significant others know the commitment that was voiced. That's another step to just strengthen that commitment. Your husband today made a big step and told me that he was ready to stop smoking cigarettes. Big step forward. Let's talk a little bit about advice giving. I already alluded to that. You know, our need is to give advice. I mean, in our field, we call it the writing reflex with an R. Writing, we need to write something that's wrong. Our first reflex is to fix what's broken. And in behavioral change, we're being told to do something opposite. So it's like, you know where the brake is. Now we're telling you the brake is on the other side because we're telling you to do everything completely different. Hold back your need to give advice, because what we have found is that people will ask you for advice when they want it. Why do we have such a need to give it when we're never asked for it? Is it to prove our superiority? Is it to prove how much we know? Why do we have such a need to give it when no one asks us for it? But it's your place to ask those questions. How willing are you to make a change? How ready are you to make a change? What reasons do you have to make a change? Why would you need to make a change? What are you going to do? And then say, do you have any questions for me? At least you'll know that they have some very clear questions and they want to know. They're open to hearing the answers by asking them, asking almost permission to ask a question, or if you must give advice, to ask the permission to give it. Mr. Smith, may I give you some suggestions related to that? Offer permission to give some advice or information. And finally, if it's not clear if the person has a problem or not, try to get that person to commit to going for an evaluation. And we like to use the term euphemistically, going for a drinker's checkup or a drug use checkup, just like a doctor's visit. You know, I don't know if you have a problem or not. I don't know if you need to reduce your use or not, but I'd like you to go see a professional for a checkup on your drinking. I'd like you to get a checkup on your substance use pattern. I'm not saying you have a problem. See, in order to just send somebody directly for treatment, that's a big commitment and sometimes scares people away. But if you could just send them for a one-time only evaluation, or what we call a checkup, it is the professional on the other end, like myself, who's now in the position to motivate them further, to stay in the program or to keep coming. Your job is just to get them to me. My job is to get them to stay. But if you start prescribing too much, it might actually make people run away. So my job is to educate them about substance use disorders, show them on forms how they responded and how their results came out compared to everyone else in the United States population, and where they are on a graph. Some of that information is very enlightening for them. Sometimes that's enough to raise enough doubt to say, I'm willing to do something about it. But it's my job to give them factual, concrete information, not judgmental and not subjective, but objective information to show that there are enough signs here indicating that you've moved into problematic use, that I think we need to consider some treatment plans around that. But your job would be to just get them to us. So, this is Social Work Month, and just wanted to speak a little bit about social workers in the field of addiction treatment. Social workers have been at the forefront of doing work in the substance abuse field, both from a research standpoint as well as clinical, for many, many years. There's over 500, almost 600 articles written on substance abuse treatment by social workers since 1977. So social workers have taken a leading role in the substance abuse treatment field. When I started in 1981, the field was just a bunch of paraprofessionals who were basically just recovering from their own addiction, and that was enough to consider themselves substance abuse counselors. The field has come a long way in those years. It has evolved. It is becoming more professional and more medically oriented in the way we do our work. So it's more than just being in recovery to say that you are now an addiction specialist. It is about getting some kind of training to do this kind of work. And sometimes when people ask me what I do for a living, and I'm feeling a little cocky, I say, I'm an ambivalence resolution specialist. Because I don't only work with substance abuse, I also work with all behavioral change. And most people that come into therapy are basically stuck. And that's why they come for therapy. They're stuck in a relationship. They're stuck in a job they hate. They're stuck doing some behavior that they can't seem to stop. And they're stuck. And my job is to unstick them. And sometimes that doesn't mean to end a behavior. It might be to just accept the behavior in one's life and move on with that. I mean, there are people who've come to see me who've decided, I don't know if I want to stop my cocaine use or, leave my job. And they decided after meeting me that they wanted to continue using cocaine and get rid of the job. And I just say, okay, that's your decision. I'm going to respect your decision. If you ever decide to go the other way, you know where to come. And they'll come back. They'll come back a year later, 2 years later, because I was non-judgmental. I was objective. I was not subjective. I did not tell them what to do. And they felt comfortable, and they come back and say, now I'm ready. So they do all the hard work on their own and come back when they want a little more support. Social workers truly, for this field, it's a great mix because social workers are really taught how to look at the individual holistically from a biological standpoint, a psychological standpoint, a social environmental standpoint. So we look at them from a whole array of different factors in terms of why somebody may be abusing substances, which is we could spend an hour in here just talking about the causes and etiology of substance use disorders. It's a little beyond what we're planning to do today. So, where do you refer people? What do you do if somebody's ready to make a change? Well, first of all, I'd like to just plug in for my own outpatient facility, InterCare. We're on 25th Street between Park and Madison. I am the clinical director there. I do a lot of the intervention work myself. We can do the evaluations and refer them, whether it's inpatient, detoxification, outpatient. We have connections all around the city and beyond. We take all insurances at our facility. I have some brochures for those of you who are interested in hearing more about our facility. I have 2 books out that may be of some interest to you to hear more about how we treat substance use disorders. A lot of what was covered today is in the Wiley book. And also you should be aware of 2 hotline numbers that is manned 24 hours a day, 7 days a week. The Office of Alcohol and Substance Abuse Services has a helpline that you can call and find out, where can I find a detox in upstate New York or Poughkeepsie or that takes a certain insurance. They will help you with that. They will assist. And then there's 1-800-LIFE-NET that's run by New York City that can find mental health as well as substance abuse services throughout the 5 boroughs. So those are 2 numbers you should really keep handy and utilize whenever necessary. They will guide you in the right direction of wherever that may be. So with that, I'm going to open it up for any questions that you may have, and please feel free to ask. And thank you all for your attention during this. Thank you. So, first question is, what are some of the stereotypes we may have as medical health professionals that can get in the way of identifying persons with potential substance use disorders? That's a wonderful question. Thank you. I mean, the stereotype is that substance abusers are indigent individuals who have poor hygiene, unemployed, and that is probably the most predominant stereotype. In fact, most substance abusers are working class individuals who are highly functioning, who keep a job, but have some abuse potential behind that, especially the substance abuse disorders as opposed to substance dependence. Very functional people. So it could happen across the whole spectrum of New York City residents. So the idea is not to have any stereotypes. Anyone can develop a substance use disorder. How best to work with someone when they are drug seeking? I would call them on it. I would tell them that it appears that they are drug seeking. You need to directly confront it. You should not hide it from them. They need to know that they're caught. That's the best thing you can do with a drug seeker. You know, we'll all try to skip around it and maybe find other reasons not to give it. I'm sorry, that they will respect you for that. As hard as it may, you know, appear, and they'll be upset not getting what they want. But beyond that, they'll respect you as a professional by saying, you know what, I believe what you're doing right now is a drug-seeking behavior, and I'm sorry, but I cannot prescribe that for you at this current time. Some good questions to identify those who are substance abusers was the question. Again, the problem with asking questions is unless they want some help, they're going to minimize the answers to any of the questions. So, you know, rather than giving you a bunch of questions, I think it's very difficult to ask that. There are some screening tools out there that I could discuss with the social work department if you're interested, that may be helpful to pick it up, even in those who won't admit to it. And that's the ones you're really concerned about, because the ones who want the help will directly let you know that. The question is, JCAHO was mentioning, or I mentioned early on that JCAHO was proposing to do some kind of screening and brief intervention as a requirement for all hospital admissions. Would that be lab tests, or would that be sort of a questionnaire? It would be more of a questionnaire. Yeah, and I'm curious to see exactly what questionnaire they have. Again, if the questions are, do you black out? Do you drink in the morning? How much do you drink? Those questions are, to me, useless. Yeah. Okay. How can you most easily integrate questions about substance use in the general medical psychosocial assessment? As medical professionals, sometimes it's uncomfortable for us to ask. I think the first question, or the first comment, is that we need to get comfortable asking. Beyond many of the medical issues that people are hospitalized for is some abuse. As I mentioned earlier, at least 25%, 1 of every 4 patients, has some direct association with abusing tobacco, alcohol, or other substances related to their hospital admission. So we must get comfortable asking that question. I think adding it in there, maybe just breaking it up rather than clumping a lot of questions together in the assessment would be helpful. But finding some good questions and just sort of spreading them out. And it might even be some of the questions I raised today with you might be helpful as well. If you know a patient is a user and possibly an abuser, and they are seen monthly for medical appointments, should I bring up their use every time? Yes. Again, this is sometimes the prominent issue in one's life, and it shows concern. And again, as long as you're not judging people behind it, but just showing concern, people, I don't care what abuse they're having, they understand it as concern. Unless you're trying to tell them what they need to do, and they feel judged by you as being a bad person. But saying, how's the drinking going? And if the more non-judgmental you can be, the more honest they will be back. So ask the questions, but try not to be judgmental. And judgmental could be as simple. Sometimes we all think we're non-judgmental. But if you're writing something down, you say, how much are you drinking right now per day? And they say, I'm drinking about 1/5 of whiskey a day. And you look up, that's a judgment. And we may not even know we're doing it. But that is a judgment. So we have to be careful about what we do. Not only what we say, but how we react. The question is it good to, in follow-ups, re-ask the question of how they're doing and their use, right? Yes, it's absolutely. I mean, people lose motivation. I mean, we know motivation fluctuates for all of us. Going to the gym, we get our new outfits and we go down there and we're going to go every day, and then 3 weeks later, I could go 3 days a week, and then before you know it, the bag is stuck in some corner of our closet. Motivation fluctuates, and we need to help people stay motivated by showing concern and questioning how they're doing. Okay, if somebody comes in the office and they storm out angry about being confronted about their use, do you follow up with a call or wait for the next appointment? Unfortunately, I have found that people die in between appointments, and I think for myself that I have learned to try to outreach people for my own feeling of that I've done everything I could possibly do. And people die from this disease, accidentally, intentionally. So I think it's important that you try to follow up, and that people may look at their own behavior when you call them up and realize that what they did was inappropriate a lot of the time. So and again, it does show concern, and that's so important, is that they feel that we do really care about them. How do we distinguish, for treatment purposes, the patient who is a recreational user from the patient who has developed an addiction to highly addictive prescription drugs? It's a good question. So if I understand the question, are they using the prescription drugs recreationally, or... Yes. Are we talking about opiates now? Opiates, painkillers?
Yes.
Yeah, okay. Well, our general rule of thumb in our field is that opiates should be used for acute pain, not for chronic pain. And you may disagree with that, but there is a tolerance that develops over time, and we would like to find alternatives to opiates for chronic pain.
How do you tell that to the patient who's coming in and saying, I'm in a lot of pain, I need that
Yeah.
stuff?
Yeah. Well, we all have to be working together on that, because if they don't like your answer, they'll go to another physician and get it somewhere else.
That's what they do.
Yeah. Yeah.
Shop around.
Yeah. But it's our job now as professionals to speak to the physicians about that as well, because sometimes the biggest impediment to our work are the physicians. So we need to work and educate and work hand in hand in terms of not enabling the patients to continue a behavior, not to continue their drug seeking, and to confront that behavior.
The physicians have two routes to go with also. They can say, I'm not here to support your drug, or they can say, I'll write another prescription. You go on to the next patient
Yeah.
and take a blind eye, because they don't want to become involved in that patient's coming back and falling.
That's right. Just to get them out of the office, it's easy just to write the script.
It's the easiest.
Yeah, and because they're so persistent, it's just like, here, just get out of here. So sometimes it's just easier. And the patients know that.
They play on it.
Yeah,
Sure.
yeah, yeah. I can only give you, the question again is, how do we make a distinction between those who have chronic pain that's legitimate and need the medication and those who don't, or do not have that legitimate pain? It's very difficult to know the difference. And again, our general rule is that opiates are to be used for acute pain and not for chronic pain. That's just the general rule for our field. And I know that there are exceptions to every rule, but that's our general rule of thumb. It's a very good question. Friends are more difficult than dealing with patients. How do we intervene with a friend who we know may have a potential problem with substance use? Clearly, it's our job as friends to mention or voice our concern. I've been concerned, and it's important that you base it on some factual information. At the party last week, when you fell on the floor, that really concerned me about your drinking. That's all. I would just leave it at that. The person has to... your job is to raise doubt for somebody who doesn't seem to be ready to take action. And that's all you can do. It's little jabs. It's not going for the gusto. It's sometimes planting the seed of doubt and hoping to sow it and make it grow over time. So sometimes it's about layers of little jabs. And that's what I like to do when it becomes more of a close relationship. Is they know what I do, so sometimes they run away when they see me coming. It's if they have some doubt already. But my job is just to raise the doubt. I think it might be doing it a little too much, just little comments, and but if you push too hard, you're going to get a pushback, and so you just got to take little steps. But again, eventually, if they're ready to do something, it would be to send them for that one-time evaluation with the professional. That's all. If you could get them to that place, you've done a great job. Well, there is something called professional. The question is, if somebody's not ready for help, can we actually push them to get the help? Is that the correct question? There are professional interventions of people who are trained to do interventions. I'm not the greatest fan of interventions because I think the pressure of a family getting together and telling somebody they need to change is clearly going to move people to take action, but the action is more of getting the pressure off of one as opposed to making a decision that I'm ready to get that help. And what I've seen over and over again is interventions are very successful at getting somebody into a facility, but it doesn't mean that they do well once they finish that facility. And if the family's going to wind up spending, $10,000 for a professional intervention and $30,000 for an inpatient rehab, I have not seen the success rates worth that kind of money at the end of that period of time. I'd rather work with them one-on-one, and even to say, I want you to just see a counselor, an individual therapist once a week, just to talk about your issues. Will you do that for the family? If people feel that it's reasonable what you're requesting, they're more apt to do something about it. Get them to come to a professional once a week. Again, it's our job then to say, I don't think the once a week is working so well. Are you willing to come twice a week? I'm not sure that twice a week is working so well. Are you willing to start to join one of my groups? Just give it a try. And for us to just gradually get them into treatment, I find much more effective. How can we support the family of the drug abuser? That's a good question. At our facility, we have a family program where just the family members can come in, even if that identified patient is not able or willing to come in on their own. We support the family to say that you need to keep the focus on yourself. The fact that the family members come for help, eventually it increases the likelihood that that patient will follow suit. So we like to get the family involved whenever possible. So you could send them down to our facility or any other facility that has a family program as well. Yes?
What about Al-Anon?
Absolutely. Al-Anon is free. They're all over the city. But absolutely, if they're willing to go to Al-Anon, for sure. Thank you for mentioning that. Last question.
Do you take any insurance?
We take all insurance. Yes. Yes. Thank you. Thank you all for your attention today.